To the last topic here, and I thought Dr. Cutler is a very appropriate person to discuss this. Is overall the exploding growth in healthcare is the cost inflation is driven more by private insurance reimbursement than Medicare actually, and why is that? One would think that private insurance might have the incentive to demand lower fees, but they don't. Why does private insurance allow for such cost inflation?
Over long periods of time, say 15, 20 years, cost increases in the private sector and Medicare tend to be about the same because what's going on in the medical system is fundamentally similar in the two. That is, you don't have a lot more care being provided to seniors that doesn't get provided to the non-elderly population and vice versa. But over particular time periods, you do see things going on that move it one way or the other. So for example, in the most recent decade, Medicare costs have been a little bit less rapidly growing than private insurance because the prices that providers charge to private insurance have been going up more rapidly than Medicare payments. In the previous decade, private insurance did better when people moved into managed care, and lots of people in the public sector did not. And so you see some fluctuations over time, but it's actually a fairly steady mix between the two. And anything that would kind of make those be dramatically different, I think we probably just wouldn't stand for. We wouldn't let access for Medicare beneficiaries get too far below or too far above what it's like in the private sector.
But before we blame the private insurance system completely, I just want to make this point that I keep making to our employees. The decisions about what to cover, private insurance does that for the individual market. They give you some choices of what you can buy. But for the group markets, the employer makes a lot of those decisions, and they have some choices about what they want to cover. Most of us want to cover all that's medically necessary. We'd like it to be as efficient as possible. But we've got to be careful not to blame private insurance for decisions that essentially employers are making in this country, or doctors are dictating because they won't go into the network without certain kinds of assurances. So the private insurance companies, there certainly are some things I don't like about the way they behave. But at the end of the day, these big, expensive insurance plans are precisely what employers that are in competitive markets want for their employees.
Is there anything with the Affordable Care Act and new health care reform legislation that addresses private insurance cost issues, or is it all focused on Medicare-related issues?
No, there's some private insurance. I mean, certainly the effectiveness research, they're not going to be able, they're going to have to cover everybody up to 26. The risk pools are a temporary solution. They're going to be restrictions, some restrictions on private insurance, not to cut people off, for example,
and not denying people,
coverage.
Conditions, the caps that are going to be different, and the preventative services.
All of this is not going to make private insurance cheaper.
No, and
go ahead, Dr. Cutler. Yeah.
Let me come to that question for a second and at least give you what I think of as part of the philosophy behind the Affordable Care Act. If you look at the cost-saving part, forget about the coverage of 32 million people, but if you look at the cost savings part, it was basically predicated on 3 points. The first one is that if we get the right information out there, people will be able to do better. That was the comparative effectiveness and the investments in IT that were mentioned. And so we're doing a lot of that information. The Recovery Act had about $30 billion of IT investment. The second predicate of it is that a major driver of inefficiency is a payment system that rewards doing too much and not providing care well enough. So make it be possible for doctors to do the right care, the right preventive care, rather than just doing more tests and procedures. The idea there was to start with Medicare, but it was fairly explicit that what happened in Medicare would rapidly transform the healthcare system. You have a lot of private insurers that are eager to change reimbursement rates and methodologies but they say we can't do this by ourselves. We can't do this without the government, which is paying for half of medical care, coming in as well. And so the Medicare part is the government stepping forward and saying, we'll meet you there. And then the third predicate is that organizations, once given the right incentives, will figure out how to really take advantage of their employees and their customers to do better. So hospitals will be able to say, you know what, in this new kind of system, we really can do better. And doctors will say, I actually can take care of my patients better and manage them better and make sure they get the care they need and stay out of the hospital. And that's really the philosophy, is that what this will spark, what the Affordable Care Act will do, is not cut a payment here or cut a payment there, but it will spark a transformation of the way that the medical system is organized for everyone, so that instead of being haphazard and do what you can and get paid for it, but it'll really be built around the patient as a whole, what works best for that patient, how do you take care of them, and how do you make sure that it's as efficient as you can. And so I don't want to point to any provision. I don't think it's the provision. It's the philosophy behind it that I hope will transform the medical system in this positive way.
And the question is it powerful enough to transform the system? We know the system's unhappy with where they are, but the question is, have we put enough incentives there, or do we have to move to the next stage, which clearly is part of the underlying philosophy, and that is really look at global payments, at rewarding value and outcome. And I happen to think that we have to go to that next stage as well. But to be fair to the president, he didn't have the politics for serious cost containment. He had the politics for investments in prevention and information, but he didn't have the politics, and so he didn't take both on directly. He took cost on indirectly, I believe, and certainly took it on in terms of Medicare, but he didn't have the politics to really mandate national demonstrations, huge new payment systems and a new incentive system.
It really did understand what you're saying, right? Or
Right.
even the drug industry was not regulated or changed as much.
No,
as
though they
been.
did give something at
Yeah,
the table. I
right,
mean, there's no
right.
question that they stepped up. But the drug situation is a whole more complicated thing, because they basically are cost shifting so that the R&D is paid for on the American taxpayer, and they negotiate deep discounts around the world. And their argument is, look, we've got to deal with those centralized systems, and the only way we can pay for our research and development, they point out, which is advertising, is by higher costs in the United States.